Hi, my name's Amy. I'm a registered nurse for Dr. Duncan Taylor, who's a plastic and reconstructive surgeon in Perth, Western Australia. Informed decisions are an essential part of your breast reconstruction journey. Dr. Duncan Taylor will now be discussing the perioperative process of an implant-based reconstruction. He'll speak through both the advantages, the disadvantages, and the risks of implant-based reconstruction, as well as tissue expanders, when they're used, and the expansion process after your procedure. Whether you've been newly diagnosed with breast cancer, you're looking at reconstruction post-mastectomy, or you're supporting a loved one, these videos will provide you with the information that you need to make an informed decision about your health and well-being.
My name is Duncan Taylor. I'm a plastic and reconstructive surgeon, and I have a subspecialty interest in breast cancer reconstruction and breast aesthetic surgery. The breast surgeon who's treating you for the breast cancer diagnosis would liaise with reconstructive surgeon and have a discussion about the nature and the biology of the cancer, and if an implant-based reconstruction was planned, this may be performed by themselves as the reconstructive surgeon or as a plastic surgeon as a reconstructive surgeon in either situation. The principle would involve an initial consultation, a discussion around reconstructive options, and if the decision is made to go down an implant-based route rather than other forms of reconstruction, then a second consultation would confirm this. It would involve a consent process and making sure that the patient was comfortable with what the plan of the process is. The surgery would be performed at in the same sitting, and for same sitting as a mastectomy under one general anaesthetic. And in that first sitting, either a definitive implant will be placed, which is the long-term implant, or an expandable implant is placed in the pocket. If an expandable implant is placed in the pocket, then it has the advantage of allowing the tissues to be redraped without the same tension as a definitive implant. And subsequently, in the post-operative period, after the wounds have healed in the first 2 to 4 weeks, then the volume of the implant, the expandable implant, can be adjusted, i.e. it can be inflated to increase the volume, to expand the tissue envelope, and to determine a definitive size for your end prosthesis, for your end implant. A tissue expander allows certain advantages in the primary setting. Those advantages principally relate to the fact that the device initially is collapsed and can be placed in the tissue pocket. The soft tissues are then draped over a collapsed or partially inflated implant. This means that they're not under tension, so there isn't the same forces pushing out on the soft tissues, which allows them to heal generally more consistently and in a better fashion in a shorter period of time. Subsequently, when the soft tissues have healed, then the device can be expanded to the desired volume. This has two advantages. One, it allows the tissues to heal and reduces the potential for complications, principally infection, wound healing, complications, and subsequently loss of the implant. But it also gives the patient an ability to allow a determination of size, which maybe create more symmetry or a desired projection size, and it empowers that person to have a little bit of control back over the journey in terms of their definitive end reconstruction. It does require then a subsequent operation, which is done a month to several months following that surgery, when the desired size and the tissues have settled, and it is replaced with the definitive implant. A direct to implant means placing an implant at the same time as the surgery, but this is the definitive implant. It's the end shape and size of the prosthesis, and the hope is that that implant will not have complications and will be there as a long term. Implant-based reconstruction has a number of short-term benefits. The principal ones relate to the fact that the implant is a prosthetic device. It comes ready-made and packaged for its intended purpose, which is to be a space filler from where the mastectomy defect has been created, and the skin is redraped over the implant. This means that there is no other effects on the rest of the body, and the surgery is contained simply to the breast. The other main advantages relate to timing and technical difficulty of the procedure. Considering the fact that this is a preformed device, there is less technical difficulty in its placement and its positioning on the chest, or its transplantation to the chest, opposed to an autologous reconstruction where microsurgical procedures have to be performed. The other event relates to timing, which is the recovery. And because the surgery is related to the chest and the breast alone, then the recovery from this generally is in the region of 2 to 4 weeks from the purposes of just wound healing on its own. Following an implant-based reconstruction, some of the consequences that women feel in relation to the reconstruction are generally that the implant is heavy and that it's cold, and it doesn't feel very natural. The implant's placed directly underneath the skin, and there's a very thin soft tissue coverage over the implant. Breast reconstruction with implant is not the same as a cosmetic implant, where the implant is placed under the gland of the breast, pushing the breast out. In the reconstructive setting, the gland of the breast has been removed, and the only soft tissue coverage over an implant is the skin itself and a thin layer of fatty tissue. This, of course, means that it's very palpable. Any changes to the implant in terms of its position or rippling or changes to the capsule are very evident and can be felt very easily. The risks of complications following implants, again, are short and longer term. In the short term, the risk of a major complication, which essentially relates to the implant being removed or having to be removed, is in the order of 5 to 15%. If this is done as a staged procedure. If this is done as an immediate procedure, as what we call a direct to implant, so if the definitive prosthesis is placed at the same time as the mastectomy, the literature on this gives a slightly higher percentage increase, possibly even up to 20%. That relates to an infective complication or a bleeding complication requiring return to theatre, or wound breakdown with exposure of the implant and the implant having to be removed. This is called a failure of, effectively a failure of the reconstructive process. A longer term failure may occur in months or more likely in the first 2 years, where you develop significant capsular contracture, that's the scar tissue envelope around the prosthesis, which develops a thick and painful capsule distorting the shape and also causing pain because of the compressive nature of the scar contracture, really requiring the prosthesis to be removed and an alternative form of reconstruction or a replacement of that implant-based reconstruction to be sought.
We hope these videos have been a valuable resource to you. For more information about what breast reconstruction options and resources are available to you, please visit Dr. Duncan Taylor's website for more information.